Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. And as you are aware that our lectures are available on YouTube, they are freely downloadable and they'll be there to stay. We also have a Telegram group where you can get all the information regarding the upcoming lectures, various links. And we have the Google Drive where all the PDF of all the lectures are available with the master integration key to navigate through them. These are the disclaimers. And this is phase 3, the recorded pathology lecture series group. And we are continuing with our dermatopathology lectures, which is Pursue 26. And today we have in dermatopathology Pursue 26Q, which is viral dermal infection. And we are streaming from Kolkata. And to talk on today's topic, we have Dr. Debojyoti Ghosh, who is an MBBS from Calcutta and MD Pathology. He's a consultant pathologist and histopathologist at the famous Charnock Hospital and the Oncquest Laboratories, Kolkata, India, with areas of interest in histopathology and cytopathology. Dr. Ghosh has multiple publications in various journals. So he will be talking on viral dermal infections. So over to you, Dr. Debojyoti Ghosh. Please continue with your lecture. Thank you.
Today's talk is on viral dermal infections. The viral skin diseases which we'll cover in this talk are herpes simplex virus, varicella zoster virus infections, human papillomavirus infections, molluscum contagiosum, and hand-foot-mouth disease. Viruses have been defined as submicroscopic germs which reproduce within the specific living cell. Virus may contain either RNA or DNA. Members of the human herpes virus and human papillomavirus families cause most of the common primary viral infections of the oral cavity. First, we'll go through herpes simplex virus infections. It's a double-stranded DNA virus. There are mainly two types of HSV, type 1 associated with facial and oral infection, and type 2 affecting mainly the genitalia. Epidemiology: HSV infection is one of the commonest infections throughout the world. HSV-1 infection commonly affecting the children. HSV-2 infection mainly occur after puberty. Close contact is required for HSV infection. After an incubation period of around 2 to 20 days, the primary attack will occur, which is asymptomatic in 90% of cases. Following the primary attack, there will be a latency period where the virus remains dormant in one of the sensory ganglion. Reactivation of the virus will lead to the recurrence of the infection. The clinical picture goes through like this. The erythematous patch develops. From there, grouped umbilicated vesicles develop. From vesicles to pustules, and then there is a crusting, and within 2 to 3 weeks there will be a post-inflammatory hyper or hypopigmentation. The clinical presentations of HSV are herpetic gingivostomatitis, herpes labialis, herpetic whitlow, herpetic keratoconjunctivitis, neonatal herpes simplex, herpes genitalis, eczema herpeticum, and disseminated herpes simplex. We'll go through few of the important clinical presentations. Herpetic gingivostomatitis. Most cases occur between 1 to 5 years. After constitutional symptoms, which may be severe, the stomatitis began. The gums are swollen, red, and they bleed easily. Vesicles present at white plaques, which is seen on tongue, pharynx, palate, and buccal mucosa. As you can see in the picture there are white plaques on the buccal mucosa. Then regional lymph nodes may be enlarged and tender. Fever subside after 3 to 5 days and recovery is completed within 2 weeks. Now, herpes labialis, they are mainly cold sores, there is fever and blisters. One of the most common variety of herpetic infections often occurs in childhood, affecting the lips, nose and cheeks. As we can see in the picture, this is affecting the lip. Commonly caused by HSV type 1, one-third of the patients will experience a recurrence. Of this, 50% will experience at least 2 recurrences annually. Herpetic whitlow occur as a direct inoculation of the virus from oral or genital lesions. Painful, grouped, confluent vesicles on an erythematous and edematous base. The disease is a common occupational hazard for medical and dental personnel who work in and around the mouth. As shown in the picture, you can see the vesicles. Now coming through herpes genitalis, most commonly caused by HSV type 2. Age of onset is young, sexually active adults. Risk increases with multiple sex partners. Primary infections mostly asymptomatic, but mild fever, headache, and local pain is noted. Distribution: male glans, shaft or sulcus of penis, scrotum and buttocks. As we can see, the picture is from the buttock, and female, the both labia, perineum and thigh are involved. Now coming to eczema herpeticum. This is also known as Kaposi varicilliform eruption. It's a HSV infection occurring in atopic dermatitis patients, characterized by systemic symptoms, example fever, malaise, irritability, and generalized lymphadenopathy. Clinical examination reveals generalized vesicles, which often becomes hemorrhagic and crusting, commonly affecting the face, neck, and trunk. The primary attack is severe, but the recurrence tend to be milder. As you can see in the picture, mainly affects the children who are suffering from atopic dermatitis. Now coming to disseminated herpes simplex, it's a potentially fatal systemic HSV infection characterized by generalized mucocutaneous vesicles, pustules, and erosions, along with widespread visceral involvement like lungs, liver, GIT, and CNS. The risk factors include immunodeficiency, example AIDS, drugs, malignancy, etc. Number two can be due to malnutrition, and also it can be a sequelae of eczema herpeticum. What are the diagnostic methods of herpes simplex virus? Direct microscopy examination, where we use the Zank smear. Viral culture is the most reliable way to make the diagnosis. Serology, PCR, useful in the diagnosis of culture, negative or atypical lesions. Immunofluorescent demonstration of viral specific DNA protein or viral DNA hybridization. As I've given a picture of Zank test where the roof of the blister is cut and the base is scraped with a cotton swab and it's spread on the glass slide. It's stained with Giemsa stain, and this slide is examined under the light microscope. In case of herpes infections, there we can see the multiple giant cells. Histological changes: there is increasing edema of the keratinocytes progressing to ballooning degeneration. There is acantholysis, irregular epidermal vesicle containing groups of keratinocytes, some of which may be multinucleated. The nuclei of keratinocytes may contain basophilic or pale ground glass inclusions. Perineural inflammatory infiltrate and superficial leukocytoclastic vasculitis may be present. The below picture shows the multinuclear giant cells and the conspicuous pale staining inclusions, as you can see. Herpes zoster now. It's acute localized viral infection caused by reactivation of varicella zoster virus and characterized by unilateral pain and vesicular eruption limited to a dermatome innervated by a corresponding sensory ganglion. The etiopathogenesis: causative virus is varicella zoster virus. The same virus causes varicella, chickenpox. During varicella, the virus travels the sensory nerves to the sensory ganglion, where it remains dormant and establish the latency. When immunity to the virus decreases, the virus replicate within the ganglion, then travel back to the sensory nerve to skin, resulting in dermatomal pain and skin lesion. There are some pictures of the clinical presentation. This above picture is of varicella, chickenpox, and the below picture is of herpes zoster, intact vesicles in a characteristic dermatomal distribution. Clinical picture: there is a prodromal stage of within days 3 to 5, then there is acute vesiculation, then there is crust formation, and post-herpetic neuralgia occurs after months to years. The skin lesions: closely grouped vesicles and pustules on an erythematous base. They may appear umbilicated. There is a dermatomal distribution as already shown in the picture, and new lesions continue to appear for a week. The sites of predilections: thoracic region is most involved, more than 50% of cases, trigeminal region 10 to 20%, and then there is the lumbosacral and the cervical region 10 to 20%. Complications of herpes zoster: there is postherpetic neuralgia, there can be ophthalmic zoster, Ramsay-Hunt syndrome, disseminated zoster, and zoster encephalomyelitis. We are not going into the details of the histological picture of herpes zoster as they are almost similar to the herpes simplex virus. Now coming to the warts, it's a common, discrete, benign epidermal hyperplasia induced by different types of human papillomavirus. Warts are very common infections all over the world. Both sexes are equally affected, all ages, but rare in infancy and common in school years. The highest incidence of common warts is between the age of 9 to 16 years, while for genital warts it's between 20 to 40 years. Warts are more common in immunocompromised patients. Mode of transmission. Major mode is skin to skin contact. Minor trauma with breaks in the skin facilitates the transmission. Habitual nail biter or children who suck their hand are at risk of auto-inoculation. Shaving may spread warts over the beard, and genital wart is one of the commonest sexually transmitted disease. Etiology is caused by the human papillomavirus. There are over 80 subtypes of human papillomavirus. It is a double-stranded DNA virus belonging to the papovirus family. The incubation period ranges from 1 to 6 months. Different subtypes of HPV are more or less causing specific clinical manifestation. Some subtypes are oncogenic, like the cervical carcinoma, which is caused by HPV 16 and 18. The clinical presentation of human papillomavirus infections: number one is the common wart, which we call as verruca vulgaris. Then there is a flat wart or the plain wart known as verruca plana. Plantar wart, which is more or less similar to the common wart, verruca plantaris. Genital wart, condyloma acuminata. Filiform wart, periungal wart, and mosaic wart. First, coming to the common warts, the verruca vulgaris. HPV subtypes 1, 2, 4, 26 and 27 mainly cause the common warts. There are papules or nodules with rough surface, as you can see in the picture. It is on a finger. They may occur singly or in groups, can occur anywhere, but most commonly over the dorsal aspect of the fingers and hands, as you can see in the picture. Characteristic black dots on the surface, which represents thrombosed papillaries. New warts may appear at site of trauma, which is known as Koebner phenomenon. Periungal warts and filiform warts are variants of common warts. The histological features of verruca vulgaris. The defining features are hyperkeratosis, papillomatosis, and hypergranulosis. There are columns of parakeratosis, especially over the projecting dermal papillae. Vacuolated superficial keratinocytes with pycnotic resin-like nuclei, which are known as coilocytes. Coilocytes may not be seen in older lesions, so they are always not needed for the diagnosis. Inward bending of rete at borders of lesion, which is known as toeing in. There are dilated capillaries in the dermal papillae, and mainly the verruca vulgaris projects above the plane of the epidermis. As you can see in the histologic pictures, you can see the hyperkeratosis and the papillomatosis in the above first picture, and the second picture on your right shows the large vacuolated cell with enlarged and irregular keratohyalin granules, and also at the top you can see the coilocytes. Now coming to the plantar warts, which are known as verruca plantaris. These are caused by HPV subtypes 2 and 4. These are rough hyperkeratotic surface studded with black dots, thrombosed capillaries which cause the black dots, usually single but maybe multiple, affecting the plantar aspects of feet or hands, as I've given a picture of a plantar wart on the plantar aspect of feet. When multiple warts coalesce into large flat plaque, it is called as mosaic wart. Parring usually using surgical scalpel will produce the pinpoint bleeding spots. Coming to the histologic features of verruca plantaris, they are more or less similar to verruca vulgaris. Clinical distinction is mainly based on the location, and they are mainly endophytic growth. Greater proportion of the lesion lies beneath the plane of the epidermis. As you can see from the pictures, mainly hyperkeratosis, there is papillomatosis, and along with it you can see the keratohyalin granules and the coelocytes. Now coming to plain warts, which are known as verruca plana, caused by HPV subtypes 3, 10, 27 and 38. These are slightly elevated papules with smooth surface. The number ranged from few to many hundreds. Skin colored, light brown, pink or hypopigmented. Shape may be round, oval, polygonal or linear lesions. Autoinoculation can happen by scratching. Common site is the face or beard area, but may be seen on the dorsa of hands. I've given a picture of plain warts over the face. The histologic features of verruca plana are slightly different from the verruca vulgaris. There is acanthosis and hyperkeratosis, but no papillomatosis or parakeratosis is usually seen in verruca plana. Vacuolization of cells of the upper stratum spinosum and stratum granulosum with margination of keratohyalin granules, which is also seen in verruca vulgaris. Often they have some diskeratotic keratinocytes. Now coming to the genital warts, which is known as condyloma acuminata, caused by HPV subtypes 6, 11, 16, 18. These are cauliflower-like papules, nodules or plaques, can cause solitary, multiple or in large masses. The most common sexually transmitted disease. Seen in external genitalia of both sexes, perianal region and in anal canal. This picture depicts a genital wart over the perianal region. May affect the urethral meatus, urethra, vagina or the cervix. Huge warts are at risk of malignant changes. The important differential diagnosis is condyloma later, that is occurring from secondary syphilis. Histologic features of condyloma acuminata. Overall, it's a verrucous or warty architecture. There is acanthosis with papillomatosis, hyperkeratosis, and hypergranulosis of the squamous epithelium. Broad papillae with rounded ends which are fused at the base. Viral cytopathic effects can be seen like variable coelocytosis and binuclear cells. Usually there is no stromal inflammation. Now coming to epidermodysplasia verruciformis, this is a rare inherited condition, selective susceptibility to skin infections with certain HPV types. There are generalized polymorphic papules. As you can see, there is a picture of generalized papules over the hand, flat wart-like appearance on the dorsal hand, neck, face and extremities. These are scaly, pink macules, hypopigmented, gutted macules or patches, and seborrheic keratosis like lesions on forehead, neck and trunk. The histologic features of epidermodysplasia verruciformis, there is hyperkeratosis and hypergranulosis, acanthosis with small nest of large cells with pale blue-gray cytoplasm, clear nuclei and perinuclear halos, it can evolve to squamous cell carcinoma. Course and prognosis. Immunocompetent individuals, cutaneous HPV infections usually resolve spontaneously. 50% of warts will resolve within 1 year, 70% of warts will resolve within 2 years. Immunocompromised patients, cutaneous HPV infection may be very resistant to all modalities of therapy. Diagnosis Diagnosis can be done by history and examination. Acetowhitening test, acetic acid 3.5% causes some subclinical warts to develop shiny white surface color. It can be diagnosed by polymerase chain reaction (PCR) or pap smear for cervical and anal warts. Now coming to Molluscum contagiosum. Molluscum contagiosum is a self-limited viral skin infection characterized clinically by skin-colored papules that are often umbilicated, occurring in children and sexually active adults. Etiology: Molluscum contagiosum virus is a large double-stranded DNA virus belonging to the pox virus family, the largest virus known. Epidemiology: skin-to-skin contact is essential for transmission of the infection. Most common disease in children and adults. Both sexes are usually affected, and more or less there is equal distribution. In children, occur on exposed skin. In adults, may occur in genital skin as a sexually transmitted disease. Clinical picture: incubation period is 4 to 8 weeks. The lesion is asymptomatic. The characteristic skin lesion is a papule, size ranging from 2 to 10 millimeter. Number, it can be single to 100. Color is pearly white and translucent, as you can see in the below picture. Histologic features of Molluscum contagiosum is very characteristic. There is cup-shaped lesion with inverted lobules of hyperplastic squamous epithelium, which expand into the underlying dermis. There is the Henderson-Patterson or molluscum bodies. These are very characteristic, up to 35 microns intracytoplasmic eosinophilic inclusion bodies. At the granular layer, the bodies become increasingly hematotoxic and occupy the entire cell. Chronic inflammatory infiltrate can be seen in regressing lesions or older lesions. The histologic features of Molluscum contagiosum, I am showing some pictures. In the first picture on the left, you can see the eosinophilic molluscum bodies which become more basophilic based on the location in the epidermal layers. In the second picture on your right, there is an intense lymphohistiocytic infiltrate. Numerous infected keratinocytes are also present. So these lymphocytes increase in regressing lesions or the older lesions. Typically benign and common illness among infants and children, characterized by rapidly ulcerating vesicles in the mouth and vesicular lesions on the hands, feet, and diaper region. It's an important public health concern because of its tendency to cause large outbreak and mortality among children. Caused by Coxsackie virus A16 and human enterovirus from genus Picorna. The mode of transmission: direct contact, nasal and throat discharges, saliva, fluid from blisters, contaminated surface, equipments and toys, fecal-oral stool from infected person. Most contagious during the first week of illness. High risk groups: children in nursery, preschool and crowded, unsanitary environment. Incubation period is around 4 to 6 days. The clinical features of hand, foot, mouth disease, as you can see from the pictures also: oral lesions 90%, sometimes the only lesion. Vesicular eruptions, it can occur on hands, wrist, soles, diaper region. There can be fever, malaise, headache, conjunctival injection, diarrhea and abdominal pain. It's usually a self-limiting illness. The complications of hand-foot-mouth disease. If it's caused by Coxsackie virus A16, it's a milder course, may develop myocarditis with intractable shock, death. With enterovirus 71, infection are more severe, complicated by meningitis, encephalitis, and neurogenic pulmonary edema. Enterovirus 71 infection can be classified into 4 stages. Stage 1, development of oral ulcer and vesicular rashes, which are on a milder course. Stage 2, it can cause CNS involvement like aseptic meningitis, encephalitis, encephalomyelitis, or poliomyelitis like. Stage 3, cardiopulmonary failure, pulmonary edema or hemorrhage, and left ventricular failure. And stage 4 can lead to convalescence. Diagnosis is mainly by blood serology, swab for viral culture from mouth ulcer, rectal swab, or vesicle base, and if it's causing meningitis, then CSF study has to be done. The histologic features of hand-foot-mouth disease. I've shown 3 pictures here. Sections usually show acral skin with a lymphocytic infiltrate, which infiltrates the epidermis, as you can see from figure 1. The infiltrate is associated with keratinocyte apoptosis in early lesions. You can see in figure 2. The figure 3 shows a high power view of a more established lesion. There is a papillary dermal edema. Lower half of the field you can see the papillary dermal edema. There is epidermal necrosis, disc keratosis, and intraepidermal vesiculation as a consequence of epidermal edema. So here I complete all the most important viral skin infections which we face in the day-to-day practice. These were my references mainly, and thank you for giving me this opportunity.